AOD. All participants joining the webinar today are in listen and view only mode. After the presentation, there will be a question and answer session, and you can submit a question at any time during the webinar. To do so, please type your question into the Q&A box located at the bottom center of your Zoom screen. You may need to move your cursor or tap your touchscreen device to see it. This webinar is being recorded today and will be available on the NADA website in the coming days. I'm Sun, I'm the Project Support Officer at NADA, and I'll be facilitating today's presentation. I'd like to acknowledge the traditional custodians of the land realm situated today, the Wadawurrung clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the dream time. We pay respect to elders past, present, and future. Today, we are joined by Annie Bleeker. Annie has worked with HIV and AIDS and alcohol and other drug sector for the past 30 years. She's lived and worked in the Netherlands for 5 years, implementing peer-educated programs for people who use drugs. She also spent 2 years working in Indonesia, training community workers on how to respond to alcohol and drug issues and prevent transmission of HIV. She has taught at several universities in Sydney and currently works as a senior training specialist for ATOTA, NADA's sister agency in the ACT. Today, Annie will be talking about alcohol, tobacco, and other drugs in New South Wales and Australia, and also give us a brief overview of the data and trends in relation to COVID-19. So without further ado, I will hand you over to Annie.
Good afternoon, everybody, and thank you, Sun, for that lovely introduction. As Sun said, I've been working in the alcohol and drug sector for over 30 years, and I hope I am able to share some sort of valuable information for you guys working in the alcohol and drugs field, but also those broader in youth and community services. So as the intro slide said, I've got a bit of a presentation for about 60 minutes. And after that, hopefully, if you've got any questions, please submit them through on the Q&A function, and we'll try and get to them later. So again, like Sun, I'd like to acknowledge the traditional owners on whose beautiful land we're meeting today. I'm speaking to you from Bundjalung country up in the Northern Rivers, and I'd like to pay my respects to traditional elders and the custodians on the land that we meet and you're meeting as well, and pay respect to elders, families and ancestors, and also extend that particularly to any Aboriginal people who are online with us today. And also I'd like to acknowledge the fact that it's NAIDOC week. And also, you know, a lot of people come to this field with a lot of their own sort of lived experience with drug and alcohol and mental health issues. So I'd also like to acknowledge you guys today as well. So what we're going to cover today is just a bit of a sort of snapshot of what's happening with alcohol and drugs trends in New South Wales and Australia. We're going to focus on the household data, which was, we got the results of that last year. We've also got some data from the Australian Secondary School Students Alcohol and Drugs Survey. Unfortunately, that data is from 2017. They were due to be in the field last year, but unfortunately, we've got a little bit of a pandemic on our hands, and I know that's affecting many of you, particularly in the Sydney region. I then want to spend a bit of time kind of exploring some of the harms related to alcohol and drug use. And then I'm just going to talk a little bit about kind of like what the research is sort of saying around alcohol and drug use trends, particularly with people's own alcohol and drug use, but I guess some of the expectations of what we thought might happen with the illicit drug market during COVID. And we've got some fairly mixed results on that. Please send any quick questions through, and we'll get to that as we go. So just to set the scene a little bit, we've got a poll here. So some of you, I'm sure a lot of you have already participated in doing Zoom seminars. This is just to make sure that you're all participating. So this was written about a drug about 117 years ago. So it was written in 1907. And it basically says the sufferer is tremulous and loses his self-command. He is subject to fits of agitation and depression. He has a haggard appearance, and a renewed dose of poison gives temporary relief, but only at the cost of future misery. So as I said, we've got, if people can fill in the poll and let me know which drug you think they were talking about, that would be great. I can see we've got 42 people online. I'm going to leave it open for another 10 seconds. So if you haven't voted, please do. and then we'll share the results of this. Okay, 5 more seconds. All right, I'm going to end polling now. Thank you for that. So share the results. So most of you picked alcohol, and only 2 people got this one correct. And the correct answer is actually caffeine, believe it or not. And I'm pretty sure everybody that was online, pretty well everyone probably had some caffeine this morning just to wake themselves up. The reason I like to start off with this drug, and there was an amazing article if people are interested finding out more about the history of coffee that was in The Guardian yesterday, which was fascinating read, is just to sort of see how we kind of like, I guess, stigmatise drug use. And this was a drug that was stigmatised over 100 plus years ago. And we can see now that it's, in fact, this is the main drug that most people use in society these days. In fact, we're all pretty well addicted to this drug. Most people need a dose of caffeine to get themselves going in the morning. You can see that it had a pretty kind of negative connotation all the way back in the 1700s. And actually 100 years before that, King Charles I decided to close all coffee houses because they were seen as sort of like places where people got together and congregated and feasibly could plan a revolution. The ban lasted for 11 days. There were riots in the street. You can see how much this guy 100 years later liked, and this is talking merely about tea rather than coffee, but you can see that tea was seen to be preparatory school for women for the brothel. And if any man be so unfortunate as to lay his hands on, fix his attention on her, she would be a food and a pest to an employer. So again, not very positive about it. Why are we talking about this one? Well, there's other ways that you can take caffeine into your body. And it's we had caffeine powder that was available here up until 2 years ago. It's now been banned for sort of sale, but we had a 21-year-old that died about 3 years ago up in the Blue Mountains. He added what is believed to be about a teaspoon of caffeine powder to his protein shake. He'd had no other drugs on board, and an hour later was found dead in his parents' bathroom. So you can overdose off this drug. You'd have to, if you were having it as a kind of coffee, you'd have to have between 50 to 100 cups of espresso. Unlikely to kind of happen. But this is in basically chocolate bars. It's in fizzy drinks, etc. So essentially, if we look at the guidelines, you can see that approximately 400 grams of caffeine is generally considered safe. So your average cup of coffee, depending on how strong you have it, if it's an espresso one, is around 80 to 100 milligrams, which is pretty well the same as a small can of Red Bull or Mother or those type of drinks. So in Australia and New Zealand, we limit the amount of caffeine you're allowed to have per day. So you, as I said before, you can overdose from it. I'm sure there's some people online that might have tried to give up caffeine at some stage and would have had really bad kind of headaches. There's some great information about if you really want to withdraw from it, do so slowly and go a little bit less caffeine and do so over 6 weeks to minimise some of the withdrawal symptoms. Good luck with that if you can do it. But if people are interested, I'm happy to send through the link for that Guardian article. It was fascinating. So when we're talking about drugs, this is the definition that we use. It was developed by the World Health Organization in 1982, and it basically says a drug is any substance which, when taken into the body, affects the physical and or psychological function. So this includes the medicines that are included on the left-hand side of your page, like psychoactive, like particularly opioids and benzodiazepines are in this class, but the legal drugs like caffeine, nicotine, and alcohol, and then all of the other illicit drugs. So why do people use drugs? Well, a lot of times when we ask people this, when I do a face-to-face training, the first thing that they tend to mention is because they're in pain. But the main reason that people try drugs, particularly in the first place, is to relax and to enjoy and curiosity and to be part of a group. And if some of us, there might be some people have used drugs online, but I guess there's probably a lot of people that might have also tried alcohol at some stage in their life. And if you think back to the main reason that you might have tried that, it was probably a lot of peer influence. Your friends were doing it and you were kind of curious about the effects. Although alcohol, which we'll talk a lot more about in the session next week, is arguably the most marketed drug in the world. So it's pretty difficult, particularly in the West, to not have been influenced by that. So usually when people get dependent on a drug, it's usually to avoid physical and or psychological pain. I think it's really important to also acknowledge that the vast majority of people who experiment with drugs don't go on to use them problematically. It's probably more like 10% of users, as a bit of a rough kind of guide with that. However, what we do know, and this is commonly referred to as risk and protective factors in the field, again, these can be both risk and protective. But if you are, connected, if you're disconnected from your family or from your community or from your school or from your friendship groups, you're also more likely to get into trouble with drugs. I guess the more of these risk factors you have in your life, the more chance you are of becoming dependent or having problems around your alcohol and drug use. Conversely, on the other side, if you're connected to family and school and peers and stuff like that, you're less likely to get into trouble with it. One very highly correlated thing is kind of like abusive relationships in the family. So if you've had any type of violence or maybe assault in your family sort of like relationship, then that means you've got more risk of becoming dependent. Trauma is incredibly highly correlated with them. In fact, 80% of people who are accessing drug treatment in Australia have experienced some form of trauma. Now, many of us have been through a fairly traumatic event in our life, and even particularly if we want to think about COVID happening in the last year, it's certainly been, particularly at the beginning of COVID, was really traumatic for a lot of us and changing the way that we kind of operate in life. So this could be a one-off event, like maybe, being in a car accident or maybe seeing somebody being killed. Maybe you've been through war or bushfires or whatever. And again, the more trauma you experience, and this is just the brain then trying to find a way of coping, and drug use can be a good way of dealing with some of those traumatic events. If people have got mentally ill health as well, they are more likely to use, and we find that particularly fairly highly correlated with alcohol and anxiety, and also cannabis use is pretty high in that group. And particularly with people with schizophrenia, they might use cannabis to quell the voices, but in the long term, what this does is basically, it's like a credit card. You'll pay for the pay for the negative effects that you'll get later. If people are unemployed or can't find work or living in a place where there's high levels of unemployment, then they're also more likely to use. If there's higher availability, and this is something we saw particularly around methamphetamine or ice in some of the rural and remote areas where there was, a lot of unemployment and high availability, people were more likely to use methamphetamines. And if you've got friends or peers that use drugs, you're also more likely to be influenced by that. Okay, so one of the things that we talk about in this field is something called drug or set or person or setting, which was developed by William E. Zimberg in 1972. And basically what he wanted to do was widen the research in talking about drugs to include a person's state of mind, because often we'll just talk about the drug and forget about the person or the setting that the drug has been used in. And what he basically hypothesized and sort of said that the response that someone will have to a drug will depend on the drug type. So obviously, whether that's alcohol or cannabis or anything else, or something illicit, how much of the drug is taken, how it's taken, so whether it's swallowed or injected or shelved, which is taking up the bum, or whether or not it's mixed with other drugs. Again, with the person, what we're talking about in the person is about their mindset. So their thoughts at the time, what they're expecting to get out of the drug, their gender, whether or not they're, that particularly women seem to be more sensitive to a lot of the effects of drugs, their previous experience with alcohol and drugs, and whether or not they've got other mental health concerns. And if we change any of these particular things, that can actually change the whole drug using experience. And the setting is also really important. And Zinberg really stumbled across this theory very much when he looked at people returning from Vietnam, from the war there, and noticed that once people had left the Vietnam and there wasn't the availability of heroin, they weren't using as many drugs. And certainly this is when methadone really rolled out in the States, because I guess the US government was really concerned that they'd have a real epidemic, for want of better words, of people coming back with heroin dependence. So it's really important just to kind of acknowledge these things while we're talking about that. I just wish I could get rid of this bar at the top. Son, I don't know if you're listening, if you can get rid of the bar at the top of the screen, because it's a bit annoying. Okay, this is going back to Drugs 101, and I'm sure a lot of people know that already. So psychoactive drugs basically pretty well split into 3 different categories on how they affect the central nervous system, which basically includes the brain and the spinal cord. And so depressant drugs basically will slow everything down. So your heart rate and your breathing and that. And basically the depressant drugs are particularly dangerous for overdose. And particularly if you have 1 or more depressant drugs on board, your chances of overdose are a lot higher. There's a few overlapping, I guess, sort of effects of drugs that we can sort of see here, in that alcohol can have both depressant and stimulant effects of it. Ketamine can have both hallucinogenic and depressant and also stimulant effects. Ecstasy is, again, in that kind of like category as well. And cannabis is often, depending on how much you have, can be either hallucinogenic and depressant effects. Strictly speaking, you can't actually overdose on having too much cannabis. So the stimulants, on the other hand, these basically drugs speed up the central nervous system, so they make everything go a lot kind of faster. They reduce appetite. And these, so if people are likely to have an overdose on these type of drugs, it's more likely to be from a stroke or a heart attack or a seizure, rather than a depressant overdose, which is more that you'll become unconscious. We don't have many people actually dying from overdoses with hallucinogens. I guess one of the biggest concerns we have with hallucinogenic drugs is that people can often get flashbacks. If not often, people can get flashbacks when they've used them, which means that and that can be quite a debilitating thing for them. So one of the other ways that we can look at kind of harms around drug use is look at the kind of like things that will happen around the time when someone is intoxicated with a drug. So this could be sort of like, when they're binge drinking, and we can see an increase in injuries and accidents that can happen as a result of that. If they've had too much alcohol and or maybe had been on a binge use of methamphetamine, and they might be coming down, they might be more predisposed to getting a psychosis, or and in rare cases some violent behaviour can happen. Obviously we can alcohol is a really great one for risk behaviour. Once the beer goggles come on, Brad the Bogan can look like Brad Pitt. People can overdose from having too much. Again, we see an incredible amount of absenteeism in the workplace related to, hangovers that people will have. And then we've got some other sort of like harms that can happen through regular use of it, and obviously there's lots of problems with, if you're, particularly with smoking, people will get kind of lung disease and cardiovascular problems and bronchitis and all of those type of things. But with alcohol, we can also get liver disease. Drugs in Australia are incredibly expensive. It's probably the most expensive place to buy drugs in the world. We pay about 4 to 7 times more depending on what drug it is. This is particularly so with tobacco, but also with a drug like cocaine. It can have an impact on relationships. And I think arguably of all of the drugs, the one that's really complicated for families to manage is methamphetamine. We've got some issues that can happen around parenting as well, and productivity. And then we've got, all of the issues that happen with dependence. And again, I'll talk a little bit more about the number of people that are likely to get dependent on drugs for different types of classes of drugs. And I guess there's a whole lot of problems, and many of you work with alcohol and drugs will appreciate how difficult it is to give up a drug. I guess one of the big issues that I'm interested, well, I'm not so much interested in, but one of the great bits of research that was done a couple of years ago in Australia around alcohol dependence was that it took up to 18 years before someone accessed help from their alcohol dependence. So that's 18 years that that person's struggling with that disease. Sorry, not with the disease, with that condition. And therefore they've got, that's a long time that they're doing harms to themselves and harms to their family. And a lot of this is caused by stigma and discrimination towards people who use drugs. So I guess the main ways that drugs are taken into the body can be looked at, like what's shown here on the left-hand side of your screen. And you can sort of see that inhalation is marginally quicker from getting a drug into your body than injecting, but you don't get as much of a kind of like high, but they pretty well follow the same type of curve when you take them. Again, this will be a little bit different depending on what type of drug it is and the psychokinetics of that type of drug. But within injecting a drug within 30 to 60 seconds, depending on what the drug is, you know, that it'll be in your system and you'll feel the effects. And injecting, as we'll talk about as we go on through this series, is obviously the riskiest way to use a drug. All of the bloodborne viruses that you can get and vein damage, etc., is really kind of like problematic. It's also much more dangerous for overdose because you're getting all of the drug in one go. Inhalation within 2 to 3 minutes of sort of like, you know, inhaling either tobacco or whatever the drug is, or cannabis even, before the drug is carried through your lungs up to your brain before you get the effect. Sublingual, so under the tongue or in the mouth, is about 3 to 5 minutes. Snorting is about 3 to 5 minutes. And shelving and shafting, so that's either taking drugs up your vagina or up your bum, can be, you know, 5 to 30 minutes, again, depending on what type of drug type it is. The reason people might shelve or shaft is because the drug will come on faster, but sometimes people have also, you know, with injecting, might have ruined their veins and need another way to get the drug into the system. Swallowing is obviously the slowest way to get a drug into your system. So depending on how fast your metabolism is, it can take between 30 to 90 minutes before it takes an effect. So that's why when we're talking about something like MDMA and we're giving harm reduction advice about them, we would sort of say, make sure that you wait at least 90 minutes before you top up again, because it can take that long before the drug actually affects you. And transdermal, so fentanyl patches or even NRT, you know, it can vary between minutes to hours. So you can either have a slow release or a fast release with that. Okay, so now I'm just going to take you through some data from the National Drug Strategy Survey. So these results, as I said, came out in September last year. Basically, this survey collects information from what's happening in average households across Australia. So it doesn't basically include people that are incarcerated, people who are living in supported accommodation or hospital settings or anything like that. It's basically, you know, and it's a stratified sample. It's about 25,000 Australians across different type of jurisdictions, rural, remote, city, all included. Also Aboriginal and Torres Strait Islanders are also included in that data. So both these surveys have been running since the 1980s, early 1980s, and this gives us a little bit of idea about what's happening with drug trends over time. I'm also going to present some information from the ASAD survey, so that's looking at what young people are doing. So for those that are working with young people, this will give you a little bit of an idea of what's happening in their cohort. Although, as I said before, this data is quite old. It's from 2017. It'll be, I think they're in the field this year, so we'll probably get the results of it next year from what's happening there. Okay, just going to do a little poll here, another poll for you. So relaunch polling, okay, cancel. Sorry, Okay, question number 2. So this is basically just to see whether or not you know or you think you know what, according to the National Drug Strategy Household Survey from 2019, which drugs do you think are on the increase in New South Wales? So I've got 4 categories there. I'll give you about another 10 seconds to answer if you can. Alcohol and inhalants, cannabis, methamphetamines, and MDMA, prescribed opioids, heroin, and illicit use of benzodiazepines. Okay, I'm going to close the poll off now. Thank you very much for that. Share the results. Okay, give yourselves a pat on the back for the 20 people that picked cannabis, methamphetamine, cocaine, and MDMA. Well done. These unfortunately, and it's really interesting, between the 2016 to the 2019 survey, we had quite a significant increase in illicit drug use, and we hadn't had that for a long time. So a lot of the surveys, a lot of the trends around illicit drug use had actually gone down. So I'm just going to look at that. So I wonder if it's okay. I'll look first at basically snapshot of tobacco and alcohol, and then I'll talk a little bit more about the illicit drugs, and then I've got some trends about what's happening generally around drug use. So we can see here that about 9.5% of New South Wales residents daily smokers, so less than the national average, which is 11%. Now, smoking's arguably been one of our best public health successes in Australia. We've done a really, really good job in getting rich white people to stop smoking. We haven't done such a great job in looking at people that are lower socioeconomic, First Nations people, people who are on opiate substitution, and those with mentally ill health. Got much, much, much higher rates of tobacco smoking. So high levels of that in social disadvantaged groups. And with the price of tobacco in Australia, it means a lot of people are going without food to pay for their dependence on nicotine. We have seen a small increase in smokers trying e-cigarettes. We've also seen quite significant increases in young people using e-cigarettes, and I'll talk a little bit more about vaping in next week's sort of session. But rates of vaping between the last survey and this survey doubled in the 14 to 17-year-olds and tripled in the 18 to 24-year-olds. So this is one area, a real area of concern for us in Australia, because I guess we've done so well with reducing tobacco in the general population. So in the 1960s, about 65% of Australian men were smokers. So we've done, in 40 years, we've done a lot of, actually it's now 60 years, gosh, where did that time go? Almost 60 years. So in 50 years, we've done a lot of really good work in this area. We are seeing more people using roll your own tobacco, and this is largely driven by how expensive manufactured tobacco or normal cigarettes are. It ranges, depending on which brand you smoke, up to $35 to $45, $50 for a packet of cigarettes, whereas roll your own ranges from $60 to $100, depending on whether or not which brand you buy again. So we can see that 3/4 on our favourite drug of choice, besides caffeine, obviously, you can see sort of 75%, almost 75%, or 3 out of 4 New South Wales people had consumed alcohol in the last 12 months. But the proportion of people drinking weekly declined between the 2016 and 2019 survey. So a slight decline to about 33%, or 1/3. About 1 in 6 of people of New South Wales exceeded the lifetime guidelines. This basically, the guidelines around alcohol have just been passed a couple of months ago, and it basically states that we should have more than 10 standard drinks per week. So basically, if you're exceeding that lifetime risk, it means that you're exceeding those guidelines, but also drinking over 4 standard drinks per day. And about 1/4 of the sample drank in excess on a single occasion, at least monthly. And so, again, pretty well on par with what's happening nationally. The jurisdiction that drinks the most alcohol in Australia is the Northern Territory. So we've about 16% of New South Wales residents have reported using an illicit drug in the last 12 months. And cannabis was the most commonly used illicit drugs, and this hasn't changed over time. But as we talked about before, that the types of other illicit drugs over the last 12 months have varied quite significantly. And we can see here that over half New South Wales residents supported, drug checking or pill testing services, which is slightly higher than the national average. The only jurisdiction that has drug checking or pill testing is the ACT, and they only do it in a festival sort of context. Now, as Sun said at the beginning of this session, a pill testing service, I've worked in the Netherlands for about 5 years, and they've had pill testing services for over 30 years, and we're still trying to get this up and running. And this is really kind of problematic if anyone follows at all some of the New South Wales health warnings. Just last week, we found that NBOMI, which is a research chemical or a hallucinogen that's reported to be up to 100 times stronger than LSD, was found in MDMA powder. And before that, we found that fentanyl was actually found in cocaine. So at least if we were able to check these, check all of these services, all of the drugs that are on sale in the black market, what we end up finding is that it actually cleans up your drug market. So I'm really in favour of this, and I wish Australia would get on board and be as progressive as we were when we last had a pandemic on our sides with HIV. And then we did all the methadone programs and rolled out harm reduction services and needle and syringe programs, etc. We used to be a leader in harm reduction. We're now an absolute laggard in that space. So about less than half of New South Wales residents support supervised drug injecting facilities. This is much higher in the ACT. So, but we've had one up and running for over 20 years in Australia, which is fantastic. And they've got two of them setting up in, we've got one in Richmond that's been happening in Victoria for about 3 years, and they're just opening another one in the centre of the city. We've been trying to get one out west for a while, but again, the New South Wales government is really not prepared to talk about that sort of thing at the moment. Okay, so this is just the illicit drug use that I was talking about before, and you can see in the green bar is the 2016 data versus the 2019. As I said before, we traditionally didn't have a lot of sort of drug use happening, increases in illicit drug use happening between, the surveys. So this is, as I said, it's done every 3 years. So the 2013 survey, we found that drug use was kind of going down. So I don't know what happened between 2016. So this is obviously pre-pandemic, but you can see that cannabis use went up quite significantly. Ecstasy use also went up fairly significantly. Methamphetamine went up slightly. So that's when we're talking about that drug, we're talking about ice. But the big drug that's had main, increases is cocaine. And traditionally, we didn't have a lot of cocaine in Australia. Cocaine is basically produced in Colombia. About 70% of the world's cocaine, even 80% of the world's cocaine comes from Colombia. That's where all of ours comes from via South Africa. And I guess a lot of sort of people I work with and drug policy researchers and drug and alcohol researchers are really concerned about what's actually going to happen to cocaine in this country. So while we've seen it increase by 1.5% in the whole age group, if we look at the 20 to 29-year-old age group, which is a time in our lives we tend to use more drugs, it's actually tripled in that age group. So it's up to 9%, and it's particularly high amongst young men. So hallucinogens also increased, and ketamine use also increased. And I'll be talking a bit more about all of those drugs in the next sessions coming up. But again, we don't know why this is happening. So methamphetamine is actually was quite low in 2016 and has increased slightly in those populations. When we had the highest prevalence of methamphetamine use was in 2007 survey, where it was about 3.4%. So I guess this is just a little bit of it. I apologise about how many words there are on their slide. And I also want to sort of say, and I don't know whether Sun's actually put it in there, but we will have a PDF of this presentation available for you at the end of the presentation so that you can have a look at it at a later day if you want to. So we have seen, as I said before, tobacco use decreasing, but we've seen an increase in roll your own and e-cigarettes. We are seeing more Australians giving up or reducing their alcohol intake. So in the 2019 survey, basically 9% of people sort of said that they were abstainers from alcohol, whereas the previous year it was about 6%. So and we saw this trend actually happening more about young people. So in the younger generation, people in my age group, which is the 40 to 50-year-olds, we're actually driving a lot of this continued, particularly illicit drug use in this area. So these were people that were probably using drugs in their 20s and they're still continuing in their 20s, 30s and 40s. So we have seen alcohol reduce and alcohol and drug use amongst younger generations. And this isn't a phenomenon that is unique to Australia. We saw this in the US, we saw it in the UK and also in Europe. So every now and then you get a kind of healthier, more health conscious, more sporty kind of generation. Some of the hypotheses around why this might be happening is, again, the use of social media. But also, I think these people are better educated. They're also living at home longer with their parents, and their parents are better educated. So there's a lot of reasons why this kind of like changes. But we often think about drug use as a problem with the young. And as you can see here, it's mainly the people over 40 that are continuing to use, except for in the cocaine, which is in the 20 to 29-year-old age group. We've seen the non-medical use of pharmaceutical drugs go down, and this is largely driven by a fall in the use of painkillers, but also you guys might remember a couple of years ago in, I think it was 2018, they reclassified codeine. So you basically needed to have a prescription to get that. So Nurofen Plus, etc. We've got some good wins with First Nations people. So we are seeing fewer Indigenous Australians smoking and drinking at risky levels, which is great news. As I said before, we are seeing smoking rates increase with socioeconomic disadvantage, but illicit drug use is actually highest in most advantaged groups, and also more with people that are in the workforce. So it's not actually the poor, they can't afford drugs in this country anyway, but basically it's your white collar type of workers. We're also seeing some reductions amongst the LGBTQI plus community and they've traditionally had double the level of alcohol and drug use that the general population have. So we are seeing some reductions in those groups. This was the first survey that we saw more people supporting cannabis legalisation than opposing it. And I'm hoping in the next 10 years that I'm still in this field that that's something that actually gets changed over that time. Because again, some of the biggest harms that happen with drugs being criminalised is that people end up in the criminal justice system. And I think that's a real area. It costs a lot of money. And often they're getting, small-time users, not the Mr. Bigs of the world that might be dealing drugs. This was also the second survey in a row that people would prefer the government spent more money on education and treatment for drug use rather than law enforcement activities. And if you currently look at what the spending is over drug use for the National Drug Strategy, basically about 65 or 67% of the money goes into law enforcement or supply reduction activities. We have about 24% that's spent on education and treatment, and a mere 1 to 2% that's spent on harm reduction, like needle and syringe programs, etc., or naloxone programs. So I think this would be one area. If I was running the country for a day, I'd certainly, and looking at drugs policy, this was one area I would look at certainly putting some more money in, particularly when you look at, the amount of people that want to get treatment in Australia but aren't able to access it. Okay, I won't spend a lot of time talking about this data because it is a little bit old, but again, it captures data from about 20,000 secondary school students. Again, it's randomised across the whole of Australia, and it's weighted to make sure that we have, the right amount of sort of socio-demographic, clusters represented as well. And it's the 12th survey after 1984. So if we look at tobacco, so again, 16% of young people in New South Wales are reported that they ever smoked. In the past year, it's about 12%. And the past month, it's about 7%. And the past week, it's about 5%. So I guess that would be, if we're looking at that 11% of the adult population are current smokers, we could sort of say in the past week that these people might also be current smokers. So it's about 5%. If we look down at the boxes at the bottom of your screen there, you can see that almost 3/4 of young people used roll your own tobacco at least once. 13% had ever vaped or used e-cigarettes. 9% had ever used a shisha or a water pipe, which is again becoming quite popular in the same way that they're vaping, and it's often reported to be, flavoured with tobacco, flavoured with, peach flavour or berry flavour or whatever. And a lot of people think that there's as harmful, but we'll talk more about that one next week. And about 8% have said they'd smoked a cigar over the time. If we look at alcohol use, again, so this is and this is going right up to the 17-year-olds. So if we look between 12 to 17-year-olds, so these people are not supposed to be drinking yet. Obviously, some of them are. So about 6 out of 10 reported that they'd ever smoked. About 4 out of 10 said that they'd smoked. This is talking about alcohol. Drunk alcohol in the past year. So that's about half the group. And about 1 in 10 reported that they drunk alcohol last week. And we'll talk a little bit more again about alcohol next week. So how much do they drink? We can see that that about almost 10% of 16-year-olds had had 5 or more drinks in the past week. And again, that had increased with 17-year-olds up to 13%. What do they drink? Well, essentially, they're drinking, 37% are drinking spirits or premixed spirits. So again, or beer, about 1/3, and 6% for beer females. And one really concerning stat there is that almost half of the people had got alcohol from their parents. And again, we know that if you get alcohol from your parents, you're more likely to get it from your friends, and you're more likely to get into problems around alcohol use, and more on that next week. Illicit drug use. So you can see here that about 1 in 6 had ever used cannabis. About 1 in 20 had used MDMA. Now, if you remember back to the adult survey, in the adults, it was 3 so this is ever used versus used last year. Again, young people are still using drugs, at almost the similar rates to what adults are. About 1 in 33 reported that they'd used hallucinogens, so LSD or magic mushrooms. About 1 in 50 had reported using methamphetamine ever. About 1 in 50 cocaine. Now, cocaine costs about $350, so there must be some fairly wealthy young people out there. And heroin, about 1 in 100. And we know basically this is taking up from 12 to 17-year-olds. So once the older that most people get, the more drug use you see in that generation. I should sort of say that where we see higher levels of illicit drug use is more when people hit university age, so 20 to 29, which is generally the time before marriages and mortgages and babies. And people have more disposable income, and they haven't got as much responsibility. So that's often why we see high levels of alcohol and drug use within that age cohort. So, again, it's, Aboriginal or First Nations people are 1.3 times more likely to abstain from alcohol than non-Indigenous Australians. About 1 in 5 consumed 11 or more standard drinks. So basically those that do drink tend to do it more problematically. Smoking rates for Indigenous Australians aged 18 or more in non-remote areas was about 40%. And if you compare that to 11% for the general population, you can sort of see what we're talking about. And in remote areas, so non-remote areas, so that city areas is 40, and in remote areas up to 60%. And over 1 in 4 reported using any illicit drug. That was more likely to be cannabis. 1 in 5 reported cannabis, and 1 in 10 had used a pharmaceutical, and 1 in 30 had used methamphetamines. All right, so sorry guys, this is a little bit data heavy, but this is the last kind of data heavy slide for you. So this is just basically looking at those people. These are looking more at a cohort of injecting drug users. So this is a survey that's conducted every year by the Kirby Institute, and it's basically a snapshot of what's happening in NSP services. And it collects the data over 2 weeks. And basically ask people about, which drug they injected, whether or not they use safely, i.e. use cleaning injecting equipment. And you can see that 1 in 5 people identified as Aboriginal. The average age of people who attended needle and syringe programs was 41. You can see they're a very disadvantaged group there. 1 in 4 had experienced homelessness, 1 in 5 had reported a mental health issue, 1 in 10 had reported being imprisoned, and 1 in 4 was being prescribed opiate substitution therapy. And about 1 in 2, or half the population that was surveyed, which is about almost 5,000 people, reported that the drug that they'd most recently injected was opioids, and that was 34% of that was heroin. So heroin is increasing again in Australia. We had a real shortage of it around 2000, but we are seeing an increase in heroin deaths happening at the moment. And about 1% said that they'd used fentanyl. And fentanyl is up to 100 times stronger than morphine. So again, and this is the drug that's causing most of the overdoses in America and the overdose crisis, and certainly contributing here, but not to the same level that we are seeing in the US. About 1 in 3 reported that the drug that they'd most recently injected was methamphetamine. 2% said they'd injected cocaine. About 1 in 7 reported injecting performance and image enhancing drugs, or steroids as they're often referred to. Again, we traditionally didn't see this cohort actually, accessing needle and syringe programs. I guess less than 50%, so 40% reported injecting daily. 1 in 5 reported sharing injecting equipment in the previous 12 months, and 1 in 4 reported having overdosed in the past 12 months. And this is a real area of concern for us, is the overdose. So again, we have a great product available that some of you, I'm sure, will be aware of, Narcan or naloxone, which I'll talk a lot about in the 4th seminar, and how you can access that in New South Wales. But this drug is really, really effective for reversing the effects of an opiate overdose. It works in 2 to 3 minutes, and there's a nasal form of it available now. If you can't wait to find out about it until webinar 4, there's some great information available. If you just put Narcan or naloxone in your web browser, you'll find out more information. And you can see here that about almost 50% of people reported that they'd had hepatitis C. And again, we have some great treatment available for hepatitis C. If you've got clients that are injecting or have injected in the past, please encourage them to go and see a GP, because the medicine to treat hepatitis C is amazingly effective, and it's also on the PBS. It has relatively little side effects, and it's really worthwhile. Getting one of the best things that they did in Australia was making this medicine available. And you don't also need to be not injecting drugs anymore. So you can still be currently injecting to get on the medication. So we're quite unique for having that availability in Australia. So just going to quickly talk about some other harms of drugs, and we're going to do another little poll here. So this basically is asking you, according to alcohol and drug experts in Australia and around the world, which is the most harmful drug in Australia. So this was a study that was basically replicated from a study that was done in 2010 in the UK. And basically 20 drug experts sat around and looked at the different effects of drugs from a psychosocial through to a sort of like a physical level, and looked at the effects for the individual as well as for the society, and map them over time. So we have 33. I'll give you 2 more seconds to vote. Okay, thank you very much. Damn it, most of you got this one right. Well done, 27. For those people who picked alcohol, you are correct. that is the right answer, somewhat surprisingly. And it's basically interesting because this was the same results that they got in 2000 when they did the study in the UK, but the other drugs were slightly different. So I'll just take you through that. So basically what they did, so these are the 20 most popularly used drugs in Australia. And this was, as I said, 20 drug experts that sat around. I'm just going to flick to the other slide for a second just so that you can see how they mapped it on and how they ranked these drugs. So they looked at the harm to users versus the harm to others, and they looked at physical, psychological and social harms, and then harms to others, also physical, psychological and also social. So that's how they come up with it. This is available in the public domain if people are interested in finding out more. So in the blue here, you've got the harm to users, the total harm to users, and in the red, you have the total harm to others. So you can see top of the pops with the greatest harms to others is alcohol with a raw score of 41. And then you've got sort of like on the harms to users of 36. So that total of that is 77, if I'm doing my maths correctly. The next most harmful drug that was sort of seen in Australia was crystal methamphetamine. And you can see here that the harms to users, so that's in the blue graph, is significantly higher. So it's very, the drugs that are like most harmful to users are obviously fentanyl first, followed by heroin, followed by crystal methamphetamine, and then followed by alcohol. And you can see the greatest harm to others is alcohol, crystal methamphetamine, heroin, and then cigarettes. Yeah, it's just a way that we can kind of like different way that we can look at harms. And I'm going to take you through some more data on that. But this is a great study if people are interested in it. Okay, another way that we can look at harms around drug use is looking at the amount of people that are estimated to become dependent on the drug if they try it. So tobacco, number one, it's, and I guess that's one we would like to, if we had our time again, there's no way that one would be legal. Estimated to be that 1 in 3 people who try it become dependent on it. With heroin, it's about 1 in 4. And with cocaine, it's about 1 in 6. Crack cocaine is slightly more addictive, for want of better words, and that's basically because it's smoked, and it's a very, very quick acting drug. So when you smoke crack, you'll get a high for about 10 minutes. So the propensity for people to keep kind of like smoking it is huge. We don't have any crack available in Australia, across our fingers at the moment. Where you tend to have a lot of crack is when there's an oversupply of cocaine, and we haven't had that to this date. Although, as I was saying before, a lot of drug researchers that are doing a lot around mapping around the sort of criminal networks and the stuff that's coming into Australia are really concerned that we're going to have real problems with cocaine in the next 5 years. And if you look at the amount of people that become dependent on it, this can be a real area of concern. This drug's really problematic if people start injecting it as well, because it's so fast acting. So whereas, most dependent heroin users might inject 1, 2, 3 times a day, maybe 4, where if you're injecting cocaine, you can be injecting up to 20 times a day. And so you can imagine the vein damage that can happen with that. Alcohol's our number 4. So 1 in 7 or 8 people who try alcohol become dependent. With amphetamines or methamphetamines, it's about 1 in 9. So again, a lot of the stuff that we saw certainly around methamphetamines and ice, you try it once and you become addicted. That's not true. You might have a great time when you use it, and particularly if you had a shitty life, and that will propel you to use it again, but it's not to say you will become dependent on it. To get dependent on a drug, you'd have to use it for a short period of time over a number of occasions. Cannabis is about 1 in 10 people, except for when you use it at a younger age. So research is showing that people under the age of 16 who have used it up to 3 times a week have about a 1 in 5 chance of becoming dependent on it. So the younger you initiate into any drug use, the more chances you are of becoming dependent on it. Sedative drugs, analgesic drugs, they're about 1 in 11. And inhalants, and I guess, we have seen quite a big increase in nitrous oxide, which again, I'll talk about a lot more on NANGs next week. seen a huge increase in the use of that, particularly amongst young people. We don't ever see people coming in for treatment for LSD or MDMA in Australia. These drugs tend to be used more on weekends or, and they're not something that people would kind of get into daily use about. Okay, just looking quickly at drug-related deaths there. We know that the main drug that kills Australians, and this is Australian data, is tobacco. So we will be, as less people are smoking, we will see this reduce over time. So it's about 18,000 people. Alcohol kills an estimated about 6,000 people. I think it's really important to point out here, and this is something that the alcohol industry's done a really good job of not letting us know much about, is the links between alcohol and cancer. And basically, obviously, the more you drink, the more chance there are of developing some sort of perhaps cancer related to it. The links between tobacco and cancer have been well established, but with alcohol, it's only really coming to our forefront now. So they estimate about 1/3 of deaths in Australia are cancer related. And we'll talk more about that next week. So it's about 7 cancers and specifically because it's swallowed. So it's, basically everything, esophagus, throat cancer, that sort of thing. So we have the other illicit drugs. They kill almost 1,900 people in Australia. So this is in 2019. Most of these deaths were accidental, so 2/3 of them. Opioids were present in 3 out of 5 in drug-induced deaths. What we also found with the drug-induced deaths that most people had 4 or more drugs on board, so polysubstance use deaths. And again, we know this is one of the really big risk factors for overdose. But this was also the first time since 1997 that we had higher rates being reported for drug-induced deaths involving heroin. So up until, the previous year, most drug-related deaths, about 70% of them were basically pharmaceutical opioids. So heroin is actually increasing, as we said before, and this is a big area of concern. Quite a significant amount of deaths involved benzodiazepines. We had almost 100 people dying of amphetamine-type stimulants or methamphetamine, and this has increased fourfold in the last, since about 2000. So this is one area of concern that we certainly have around methamphetamine. And we had 20 deaths involving cocaine. So I guess once we start to get more people using cocaine, we'll start to see more problems around this. Okay, this is just a little bit of a snapshot of, and again, apologise for a lot of information on this slide. This is just looking at drug-related hospitalisations. This just came out last week. And you can see that about almost 62,000 people were admitted to hospital because of drug-related hospitalisation. Almost equal parity between male and female. Highest percentage of drug-related hospitalisations occurred again in that age group of 20 to 29 when we're more likely to be using drugs, but also 30 to 39. And you can see there that amphetamine and other stimulants is a quarter of all reasons that people are coming into hospitals. About 15% for anti-epileptic and sedative drugs, 14% for opioids. So it's interesting that the prevalence of methamphetamine is so low, yet the harms of it, i.e. accessing treatment and health services, is quite high. What I found really interesting too when looking at this data, particularly if you look at down the bottom there, the red that I've highlighted down the bottom, you can see the different type of drug presentations that are coming in different type of areas. So the highest rates of opioid and cocaine related hospitalisation were in the major cities. Amphetamines and other stimulants were in outer regional areas where we've known that there was more crystal methamphetamine. And then in the very remote areas, and this is an area where we have high First Nations populations, the main drug that people are admitted to hospital for is cannabinoids or cannabis. So again, that's just an interesting kind of snapshot. Okay, question for you and our last poll for today. So which drug do you think most people seek treatment for in Australia? Is alcohol. My apologies about that. I don't know what happened there. Okay, so basically, I just want to talk a little bit about alcohol and drug treatment before we talk about kind of COVID, and then I'll look at looking at your questions. So we have about 200,000 people that are seeking treatment for alcohol and drug use a year, but there's almost double that that basically want to get treatment, but they can't get it on any particular day. And I guess what this means, okay, I don't know what's happened with the polling. We've got double the amount of people that want to get drug treatment but can't. It's a really, really cost-effective thing to do, and the earlier people get people into treatment, the better the outcomes are for them. And for every $1 that we invest in alcohol or drug treatment, society gains 7. So we've got to be starting to do more in this area and lobbying in this area of local members to get better services up and running for alcohol, and better service planning, particularly out in the rural and regional areas. So the main form of drug treatment that people are seeking is counselling, so almost 40% of all episodes. And the main drugs that people are seeking treatment for is alcohol. And I guess alcohol makes sense because that's the main drug that we're using. But again, if we look at the low prevalence of methamphetamine, which was about just over 1%, you can see that over a quarter of people that are presenting to drug treatment services in Australia, it's for treatment of methamphetamine. Cannabis is also quite high, whereas when I started in the field 30 years ago or 20 years ago, and I worked at a drug service, we would basically not see many people come in for cannabis. In fact, when you used to ring up, people would sort of say, oh, go away and come back when you've got a real drug problem, whereas you can see quite a significant amount of people seeking treatment for their cannabis use, and only 5% for heroin. So this was based on about almost 500 publicly funded alcohol and drug services in New South Wales. Okay. Almost lucky last slide. Just talking a little bit of sort of stigma and discrimination, and this is one thing that basically drug users and people also with mental health issues suffer a lot from, and basically 80% of people who inject drugs have experienced some form of discrimination. Important that we try to do something better around it's not stigmatizing people. If we were doing this face-to-face, I'd do another exercise with you just around checking our own stigma and discrimination, what we bring into our conversations with people who use drugs. So basically what this means is that people don't seek treatment, or they delay seeking treatment. They might not access sterile injecting equipment. They might not call an ambulance to assist with a drug overdose. They might not access healthcare for a drug-related medical issue. They might be reluctant to raise their use. They have very low expectations of healthcare, poor self-esteem, and they might increase their use to cope with all of that stigma and discrimination. NADA produced, in conjunction with the New South Wales Users and AIDS Association, this amazing resource, which just looks at us checking our language, and so not using words like abuse and not using words like alcoholic or, addict or junkie or whatever. So please avail yourself of this on the NADA website. It's really good. Okay, so COVID, as many of us know, is still with us. Will be with us for the rest of our lives, I reckon, although we will come to a stage where we manage it. I guess taking you guys back too much last year, there was a lot of panic, particularly in Australia, all around the world, about how we were going to handle this. And basically, the Australian government did a lot of kind of like things to try to control the spread of it. The lockdown really kind of freaked a lot of us out. We spent a lot of time working in our sector looking at whether or not, what were essential services, and obviously alcohol and drug services are essential services. And we needed to look at different ways of being able to look after our clients, whether or not that was about takeaway pharmacotherapies, about access to needle and syringe programs or naloxone, etc. So all non-essential services were closed. You can see the panic buying here that happened with alcohol. So this is a photo that was taken at Dan Murphy's at the end of March last year. Alcohol was considered an essential service, whereas it wasn't in South Africa, and there were riots on the streets. But people were only allowed to buy equivalent of about 150 standard drinks in one transaction. So there was a lot of hypotheses about what might be happening here. And I guess because we're not necessarily a producer of a lot of drugs besides kind of like cannabis, but a lot of our illicit drugs come in. And we know that about 85% or not up to between 85 to 95% come in on air, through air. And so with about 97% of all flights cancelled, we expected there would be a huge change in the amount of availability of illicit drugs. What this actually told us is that the drugs market, the basically illicit drugs market a year later seemed to be barely pandemic proof. We had a few studies from ANU and NDARC and FAIR and UNSW. These are still continuing on, and they've found very, very mixed results with regard to what happens with people's drug use under COVID. I guess in the initial stages, in the first 3 months of it, we saw quite a lot of people increasing their drinking. But then as we kind of like settled into the new normal, this kind of normalized for a lot of people, except for those that had mentally ill health. So again, those that already were struggling, they tended to increase their drinking, whereas most of us that didn't have, other problems tended to just kind of like, once we adjusted to it, started to drink in more normal patterns. So, the NDARC studies, the ADAPT studies, they're available online, suggested increasing alcohol and cannabis consumption in the first 3 months and reduced use of stimulant drugs like cocaine and MDMA. And I guess that makes kind of sense, is that a lot of people, it's not as much fun going to a Zoom party online, taking cocaine and MDMA, these are drugs that are basically used in kind of like social settings. What we did start to see is that the amount of spending changed. So we were spending more money on takeout alcohol rather than pubs and clubs because these were kind of like closed, but this was pretty well offset. I guess the main drug that people were reporting that they, certainly people who inject drugs, found that the quality and purity and availability of methamphetamine started to get really poor at the end of last year, but that seems to have kind of returned to normal again. And that was the same with heroin, that was reduced in late 2000. If you ask the police, they just reckon there's no change at all. Everything's pretty well back to normal now. The prices are the same, availability is there. So, and the police estimate they get 5 to 10% of the stuff that's imported to the country. So, I guess where there's a will, there's a way. And again, we found fairly significant levels. I guess just finishing off with a couple of questions or pictures. I mean, what will our going out look like when we're in the future? We started to see some experiments about this in Europe last year, where we had concerts and DJs playing in car parks or drive-ins. People beating their horn and stuff like that. Some outfit in LA have produced the pandemic rave suit, which is pictured here on your screen. Again, it looks a little bit like the hazmat suits that were out in the early 90s when the raving stuff was happened. But again, it looks a little bit too futuristic. In the Netherlands last year, they had a kind of like 40 people attend a DJ and they all had to sit socially distanced on a chair and do some chair dancing there. And then we had a socially distant concert in August next year. Let's hope once the vaccines get out that we can be a little bit more normal. Okay, so just to conclude, there's some good stories in there. Young people are using less drugs. There has been increases in illicit drug use, particularly over the people over 40. We can measure harms of drugs in lots of different ways, and alcohol remains our number one problem. And alcohol and drug use remains pretty kind of prevalent during the pandemic. So I guess the biggest kind of problem that we had is that we found that the long-term health impacts of COVID are still unknown, but we know there's a lot more people basically accessing treatment and care for mental health, and particularly down in Melbourne where they suffered 6 months of lockdown. It's very difficult to get mental health care. Okay, can see some questions there. Sun, do you want me to have a look at them?
I can ask you
Sure.
them. So just to remind everyone, you can still submit questions. It's just at the bottom of your Zoom screen. You might just need to move your cursor to be able to see it. We have a few already. So I know we're talking more about this next week, but someone has asked for more information regarding vaping affecting young people.
Yeah, come to the seminar next week because we... Look, I think that there was, if you can't come to the seminar next week, what I can recommend is that there's an amazing presentation that was done last week on the Positive Choices website by Professor Hayden McRobbie, and it's only 30 minutes long, and he summarises all of the evidence, and it's fantastic, and it's really, really good information for you. So if you have a look at Positive Choices webinars, basically that's available, and it's really good. It's only 30 minutes, and he just summarises everything you need to know about vaping in half an hour. So if you can't wait till next week, have a look at that one. And but it's quite a confusing area, the vaping stuff, and I think we've done real, it's very polarising debate. So I'll leave that one till next week, if that's okay.
Perfect. And then someone has also asked, how do patterns of drug use in settings like prisons compare to patterns documented in the National Drug Strategy Household Survey?
Yeah, totally different. I mean, there is some specific studies on drug use happening in prison. I mean, it's really interesting. Of the people that we surveyed through the NSP survey, about half of those who had been in prison reported that they'd used while they were in prison as well. So, they're, about 80% of people that are in prison are there for some drug-related cause, whether or not that's, being possession of drugs or dealing drugs or, robbing houses or people to get there. So, I mean, there's a lot of, even though, most prisons are in Australia now are smoke-free. I guess there's probably not alcohol in there, but there certainly is illicit drugs coming in there. But there's some, Sarah Lani has done a lot of work in this area around that, about drug use in prison, particularly around hepatitis C. And we know a lot of people are injecting drugs while they're in prison too. So, a lot of people go into prison without hep C and come out with hep C because, like a needle in a prison can cost up to $1,500, and it's used by a significant amount of people.
The next question was, what are some of the main barriers to getting drug checking and pill testing services off the ground in Australia?
Oh, God. Basically, government's inaction, I think, is the main barrier. And I think, particularly in New South Wales, this is a really big problem, and it won't happen under this kind of like government, under Liberal government, or this current Liberal government, because they basically see it as, saying that it's okay to use drugs. And that's the main argument for it. And it's sending out the wrong message to young people, which is just bullshit, excuse my French. They've found no increases in people using drugs. And just because there's a checking service, it doesn't mean that those of us who are not using drugs would suddenly go out and start taking them. I guess I worked on the pill testing service in the Netherlands while I was over there and it was fascinating just to sort of see how it actually all works in operation. I think we need to move away from actually having it in a sort of like at a festival setting and just actually have it happening in a community where you can kind of drop it off. So that and then it's tested by lab, and then you get your results within a week. And that's how the system works in the Netherlands. It's been really effective. And as I said, one of the good things that happens from it is that people actually end up, it cleans up your drug supply. So we don't get those type of adulterants that we're seeing here in Australia. And Australians love their drugs. We're prepared to pay a lot of money for them. And I guess, we need to do better than just giving out health alerts after people die or get really unwell with them. And it's a really easy, kind of ineffective way to be doing it. So I think it's just obstinance is basically the barrier. The ACT government have taken it on. They listen to the evidence. There's so much evidence about that proves their effectiveness that we really need to get our head out of the sand. But we've dragged our feet on all harm reduction services lately. So that's my view of it. Monica Barrett, if people are interested in that's really written a really good paper that's available on the NDARC website that's just done an overview of kind of like drug checking services and how they work and the best models that are available. So I'm happy to send that through to people if you want to email me. This is my email's not there. My email is annie@anniebleeker.com. If you want to email me that, and I'll send it to you.
We'll include it in the email where you get the PDF of today's presentation as well.
Sure. Yeah, I can do that. I'll do that. Yeah. So basically, yeah, I'll send Sun a PDF of the presentation, and I'll also send you a PDF of that. Yeah. And I might include the the copy of the thing around caffeine, because I think that's really interesting for those that are interested in finding out how bad caffeine is, but it keeps the Western world running.
Someone's also asked, I think it follows on nicely from the last question, was why do you think cocaine has become so popular in Australia?
Yeah, look, I think the cartels have realised that Australians pay a lot of money for their drugs. Like we traditionally, I mean, where you are situated in the world will very often determine your drug market. So because we're in sort of like, part of sort of like, I guess, Oceania, which includes Asia, we have a lot more methamphetamine than other countries do. So Australians are the biggest consumers of methamphetamine, and that's largely due to our proximity. Now, traditionally, we didn't have a lot of cocaine available in Australia because we were so far away from where the trading route was. But I think Europe's been awash with cocaine, America's awash with cocaine, the UK is awash with cocaine, and I think they were just looking for different markets. So we've seen increases in cocaine like about tenfold in the last 5 years of the stuff that's actually coming in. Yeah, I think we've got an insatiable market for drugs. Again, when I was working in the Netherlands, people were paying about $80 for a gram of cocaine, whereas, we're paying up to $350 per gram of cocaine. So if you get 10 to 15 lines out of a gram, you might be paying about $25 for a line of cocaine that lasts for about an hour in the effect. So, yeah, I think it's due to our proximity of where we are in the world that stopped us from basically having a lot of cocaine in the first place. I mean, it's interesting, when I was working in Indonesia, up until just before independence from the Dutch in Indonesia had massive amounts of cocoa plantations, and they ripped those out. So if they'd stayed there, I think we would have had a lot more of a problem because of our proximity to Indonesia than we did a lot earlier than we're going to be coming now.
That being said, you've spent a time in various countries. Do you think that the way drug harms are ranked is different between countries, or is there an international standard that's used?
Good question. I mean, it's interesting because if you compare us to the study that was conducted by David Nutt et al., which was done in 2010 in the UK, like crystal methamphetamine was like number 18 on their list, whereas for us it's number 2. So I think the reason that it's number 2 for us is that we see, and this is done by people that work in drug treatment and drug policy, is that this drug is a lot more of a problem in Australia. As you can see, it's the second most popular drug after alcohol that people are seeking treatment for. And I think arguably of all of the drugs, I think the one that's most difficult for families and people and loved ones to manage once people get dependent is crystal methamphetamine. And this is because of the emotional deregulation, et cetera, that kind of happens with that and psychosis. And that can be really kind of quite frightening for families. So I think it's the context of the drug use and looking at all of the different kind of like, treatment services, availability, all of that type of thing that impact on, the harms in a particular country. So, I mean, the good thing is we both agreed on alcohol, and I think, as I said at the beginning of this sort of session, it's one of the most heavily marketed substances in the world, and it's one of the hardest ones to give up once people become dependent on it.
And given the variety of reasons that people start using different substances, do you think as a sector it would be beneficial to improve a client's mental health first versus or treating drug reduction?
Yeah, I mean, look, we this is an area that is really badly done in everywhere, actually. I mean, and we have this no wrong door policy, but these people that have drug and alcohol and also mental health tend to fall through the cracks a lot. Basically, and they get shunted between services. It's like, come back to us when your drug and alcohol problems sorted, then we'll look at your mental health. And the two of them are often so inextricably linked. The Matilda Centre, which is based at the University of Sydney, have some really great resources on drugs and mental health and substance use. So if people are interested in more information about that, I'd suggest you go there. There's also a really great package that, and Positive Choices is run out of them as well. There's some really great information available. They've just developed a trauma module, and it's for online modules on mental health and trauma and drug and alcohol use that I think it's worthwhile looking at.
There's also a question that asks, could you elaborate on, for every $1 spent in alcohol and drug treatment, society gains $7?
Yeah, so this is basically just about the harm that is done to the individual the longer that they delay that they seek treatment for. So treatment is pretty kind of inexpensive compared to that person continuing to use drugs. So that's some modelling that was done by Alison Ritter and co. Again, a great study. It's called the Horizon study that just looked at kind of like, if we invested more in treatment, and it's similar things that we did. So these are fairly sophisticated, epidemiological sort of modelling studies that just look at kind of like, if we spend more money in treatment, how much reduction in kind of like costs would that be in the harms that that person will cause to society the longer they go untreated. And Alison's report's a really great summary. It was done in about 2012, but it's a really good summary of what's happening with kind of drug treatment here in Australia. So that's called the Horizon study, if people are interested in that one.
We do have time for a few more questions. So I'm just looking at the chat as well. Someone has asked, do you think if cannabis was legal, we would see similar health effects that we do with nicotine, especially as cannabis is normally mixed with nicotine and then smoked?
Good question. We'll be speaking a lot more about cannabis next week again, but about 70% of Australians mix, nicotine with their cannabis. Cannabis also contains 3 times more tar and 5 times more carbon monoxide than a standard cigarette, which basically means one joint is the equivalent of 3 to 5 cigarettes in kind of lung damage. So again, I guess that's a really good thing to because a lot of young people will do the big, it's safer than smoking, or it's a herb that God gave to us and we should all embrace it wholeheartedly. What they found where people have, I guess, decriminalised or legalised cannabis is it hasn't led to more use of the drug generally. So the ACT 2 years ago basically legalised cannabis, and they haven't seen increases in cannabis use. And this has been found in many kind of jurisdictions around the world. So I think, there's different models of legalisation and decriminalisation. I think it's inevitable, particularly in the next 5 to 10 years, that cannabis will, it's decriminalised in 3 states already in Australia, the ACT, South Australia and the NT. And I think that's a good thing. I guess if we talk about kind of legalisation, we have to think about kind of like who's going to regulate it. Is it going to be government controlled? If it suddenly becomes a business, then we're in the same problem that we are with alcohol and tobacco, and that they're heavily marketed to us and they find sneaky ways of kind of getting in and selling their product to us. So yeah, I don't know if I fully answered that question there.
There's also one going back to alcohol for a second. Do you think some people may not seek treatment for alcohol use because they don't feel it's problematic, given that they see it as normal because of Australian culture, as Christian culture?
Yeah, good question. I mean, I think I think really, you know, that data, and that's really kind of powerful stat. I reckon. I know when I heard it about a year, when I read the study a couple of years ago, I was like, wow, that's amazing. I think a lot of the reason that is a stigma and discrimination is that why, you know, and we'll often kind of like, I mean, I have someone very close to me who's really struggling with their alcohol use at the moment, and it's really about being able to be honest about, and when doctors ask people, and often, you know, how much alcohol do you drink, people will halve the amount that they actually drink because they don't want to be the outlier. We don't want to be the one that drinks more than anyone kind of like else. So I think alcohol is probably one of the hardest drugs to give up because it's a bit like food. It's everywhere. It's often easier to get an alcoholic drink at a function than it is to get a glass of water. It's marketed everywhere you go. It's sort of, you know, and particularly in Australia, it's sort of seen as, you know, we had it as a currency here in New South Wales with the rum corps, you know, when this country was colonised 200 plus years ago. So we have a really, and I think the reason we have a lot of binge drinking happening in Australia is because we had a lot of policies, particularly up until the 1960s and 70s, that were prevalent in Australia, which was that all pubs closed at 6 o'clock. And so basically what happened is people had to get as much alcohol in their bodies before the pub closed. And so we developed this kind of like model of drinking that we have, and we have quite a different relationship with alcohol compared to European countries that will drink in moderation, whereas we'll drink until oblivion, until we fall down. Thankfully, young people are kind of reshaping the culture on that, and that's a good thing. But I think the main reason people don't access help is they don't know where to go, they don't know where to start, and they're embarrassed about it. And they, you know, I mean, there's nothing more, you know, challenging, I guess, than being dependent on alcohol and drugs in a lot of ways, and having mental health problems.
I'm very conscious of time, so I think we might leave it there. I'm very aware that there's other questions in the queue, and we'll pass those along to Annie, and we'll get you some answers in the coming days. So I'd like to thank Annie so much for that presentation. It was really insightful and engaging, and I'm sure you all found it equally as valuable. And thank you all for participating, and stay tuned because the next webinar in the series will be next week, Wednesday, so the 14th of July at 12 p.m. as well. And you can register on the NADA website if you haven't done so already. So there's also a short evaluation survey that will be emailed to you shortly that we would really appreciate your feedback on. And also visit the NADA website for further resources, sign up to our regular emails and our publication, The Advocate, and also to view this recording, which will be available very soon. So thank you so much again, Annie.
No problems. I just put my email in the chat function too for people. If you were embarrassed to ask something here and you want to ask me separately, I'm happy to respond to that. But all the best, and we'll see you same time, same place. I didn't get into kind of referral information, but hopefully you've had a little bit of a taster and we'll spend a bit more time looking at this. But you can also get a copy of my slides, sort of where I think you should go for more evidence-based information about alcohol and drugs if you can't make other sessions. Thanks, everyone.